Good morning, my name is LAURIANE EBERST. I'm a medical oncologist at the Centre Léon Bérard in Lyon. I'm very happy to be here to present you this modest work. It deals with surgical resection of brain metastases from renal cell cancer. And we ask the question, is it worth it? Why do we ask this question? As you know, brain metastases from renal cell carcinoma are at quite hemorrhagic risk. So it is not an easy surgery. Brain metastases concern among 10% of patients with renal cell carcinoma. These patients are treated with VEGFR tyrosine kinase inhibitors, but these drugs have limited penetrance in the brain. So local therapies like radiotherapy or surgery still remain very important treatment options. And guidelines recommend surgical resection of 1 to 3 brain metastases. However, these guidelines concern brain metastases in general, regardless of the primary subtype. So we performed this trial with a descriptive objective. We just wanted to describe the outcome of these patients, and we set up a database with including all patients undergoing surgical resection of brain metastases from renal cell cancer during the last decade in our institution in Lyon. And patients were identified through keywords in the informatic medical files. We performed really classical statistical analysis, univariate and multivariate analysis. And we identified 26 patients. That's not much. And you can see that patients were quite young. They were men with clear cell renal cell carcinoma, with in 80% no presence of sarcomatoid component, which is an aggressive component. But patients had quite high Fuhrman grade, since more than 50% of patients were grade 3 or 4. At the brain metastasis stage, patients still had a quite good performance status, 0 or 1 for more than half of patients. And they developed their brain metastasis after a median duration of 19 months after primary diagnosis. And brain metastases occurred during a first or subsequent progression in the majority of cases. And all these patients, or quite all, had other metastatic sites. What about the brain metastases? They were localized they were subpotentorial in the majority of cases, of quite a small diameter. And importantly, they were diagnosed because of clinical symptoms in 77% of cases, and the most frequent symptoms being headache or focal deficit. What was the patient's outcome? You can see that only 5 patients underwent postoperative radiotherapy. Overall, 12 patients didn't experience any brain metastasis recurrence at all, and 14 patients had brain metastasis recurrence, mostly at a distant site in the brain. And among these patients, 9 underwent local therapy again for this brain metastasis recurrence. Why did the patients die? Mainly because of extracranial progression, and only here, in this small series, 2 patients died from isolated neurologic progression. This is the overall survival curve. For the whole cohort, you can see that it was quite good, I think, 23 months. We performed a multivariate analysis to identify prognostic factor. Here, these curves show that median overall survival is significantly improved when the interval between primary and brain metastasis diagnosis is longer than 12 months. When it is shorter, you can see that patients die quite quickly in about 6 months. And this is multivariate analysis according to the extracranial disease control. Here again, when the extracranial disease is controlled, you can see that patients have a really quite long survival, but here again, the effective is very small. So finally, Is it worth it? I think that it is. In this small and retrospective monocentric cohort with very few and selected patients, overall survival was 23 months, and it was significantly improved when extracranial disease was controlled, and when the interval between primary and brain metastasis diagnosis was longer than 12 months. Since only 2 patients died from isolated neurologic progression, we can say here, like in many other cancers, that prognosis is driven by the extracranial disease, and as medical oncologists, we have to probably improve our systemic therapies. And in our experience, local therapies, surgery, and stereotactic radiotherapy seem to be good options for patients with a single or 2 brain metastases. Thank you for your attention. I thank my collaborators at the Centre Léon Bérard too. And if you have some more time in this weekend, you can also come to Lyon, which is a very beautiful city.